Home Health CAHPS update, getting the most from your CAHPS surveys. What we're going to be talking about today, let's see if we can advance that slide, is again a little bit about what the CAHPS surveys are about and really what the future holds with CAHPS surveys, with Medicare, and then talk a little bit about getting a better response rate because that's important for you as an agency, and finally improving your response rate. And I have some very fresh information that I downloaded off the CMS database in regards to benchmarking information so that you can kind of get an idea of where you kind of land compared to other agencies. And of course you get your report that gives you that information as well. But I actually went and looked at, you know, what are the top 5% agencies, where are they scoring, where's the bottom 5% scoring. So I just want to make sure that everybody understands what the CAHPS surveys are about. And CAHPS itself is an acronym. There used to be a lot of confusion over this acronym. People thought it was something to do with CHAPS accreditation. But CAHPS is a series of surveys that was originally developed by the AHRQ, which is the Agency for Healthcare Research, in conjunction with CMS, to develop standardized instruments to measure and a patient's experience with care. And notice I say patient experience, not satisfaction. It's not a satisfaction survey. There are questions in it that speak to the patient satisfaction, namely what we call the global ratings, but the bulk of the survey is situated around what the patient's experience of care is. Because as we all know, you know, when you look at how you measure satisfaction, satisfaction is measured against people's expectations. And if somebody has unreasonable expectations of what, you know, what you should be providing, even to the, you know, degree that they expect you to, their expectations are that you provide services that Medicare doesn't allow or doesn't reimburse for, then they're going to have a very low rating of your agency because you're not meeting their expectations, even though you would never meet their expectations because it's not allowed as a Medicare agency to provide that service. And to give you a, you know, a quick example of what those things could be, I mean, it could be simple things like they expect you to be there and do all their housekeeping and provide meals and transportation and all those things that a private pay agency might provide. Well, if that's what they're expecting from their Medicare home care services, then they're going to be, you know, very disappointed with you, and that is not reasonable, and nor is it an accurate measure of the care that you're providing. So it is an experience survey. So the survey questions not only have the satisfaction questions, and there's really only 2 satisfaction questions in that 47 question questionnaire. A lot of them relate to experience of care, such as, you know, did your provider talk to you about your medications? Did they discuss pain? Did they discuss home safety? You know, did they communicate well in a way that you understood? So they ask those specific questions about what you experienced when you got the care. So that CAHPS stands for Consumer Assessment of Healthcare Providers and Systems. The other thing to note here with that name is it's not just home care that is doing CAHPS. Hospitals have been doing CAHPS for quite a while now, longer than home care. Healthcare provider systems, such as, you know, managed care organizations, health insurance, have had their own CAHPS surveys. Recently, they rolled out ICH CAHPS, which is for renal dialysis centers, not home dialysis, but actually in-center home dialysis. That's what the ICH stands for. Physician group practices are doing what's called the CG CAHPS survey, which is clinical group CAHPS. Hospice just recently, right now, I mean, they're just, April 1st was the first month that surveys went out to decedent caregivers, not to patients, because the patients have deceased when the survey goes out. So CAHPS surveys are going to be rolled out amongst all the healthcare provider systems if they haven't already been doing CAHPS. The program itself was initiated in 1995 to assess healthcare plans, so that's how it really started. And it is a standardized survey instrument and data collection methodology, and that's one reason why they they really insist on having that outside vendor is they want to be able to make sure, they'd rather have 30 or 40 vendors that they can control. And the vendor protocol guidelines book for home health CAHPS is 350 pages long. So there's really a lot to creating that standardized survey and the way that we report data up to Medicare as a vendor, and to make that survey a valid instrument for evaluating home health agencies. It has to be, you know, comparing apples to apples and oranges to oranges. So everybody has to deliver that survey in the same manner. And the purpose was to empower consumers with quality of care to make more informed decisions about their care, to stimulate and support providers and clinicians to improve the quality of care, and to enhance public accountability. So they want to get the public and consumers involved in making decisions about their health care. One of the things that's important to keep in mind about home health CAHPS, I mean, there's a few things. First off, you can do the surveys in 3 modes, mail, telephone, and mixed. We are approved for mail in home health. We do other venues for surveys. For example, in hospice, we will provide hospice surveys in telephone and mixed as well as mail. We decided with the home health, because of the length of the survey and the type of patient we were surveying, which was a patient that was actually experiencing an illness or just in the stages of recovering from an illness when they received that survey, and their age group, that we were having some issues with that, the length of the survey in the telephone mode. We're looking at possibly doing telephone and mixed mode again. But we were challenged a little bit when we first started doing, and we first started doing telephone modes as well as mail. And we were just finding that it was very hard to push somebody through that whole 47-question survey. You either, you know, you pushed them kind of even beyond what they wanted to be pushed, or you had a lot of break-offs. The other thing to keep in mind about the CAHPS data is the data that we actually end up reporting to CMS is completely de-identified. There's nothing in that data that would allow CMS to determine which patient received it, you know, which patient we're talking about, which patient is saying what. They understand it is a patient that was served by a particular home health agency. They cannot see who that patient is. We take all the identifying information out of the information that we report to CMS. We create a unique patient ID number that is never repeated. And for the people that receive the survey, it's important for them to understand that that information is not shared with CMS or anybody, including the home health agency, related to their name unless they give their permission to do so. We can provide aggregate information, like you had 100 surveys, and on question 1, you know, 26 people answered yes, 48 people answered no, and the rest of them, you know, failed to answer the question. That's an aggregate answer. In order for us to say, you know, Mary Jones said no to this question, and it was Mary Jones that said no, the patient itself has to give us permission to do that. And it's important to include that optional question 35, and I keep on saying 47, 48 questions. That's hospice CAHPS. There's 35 questions in your home health CAHPS survey. And that question 35 is the question that gives permission. We include it, even though it's optional, as standard, and we'll take it off if you want it taken off, but basically that question is provided on all our surveys. So in case we do get an answer, we do get somebody that says something, maybe even writing a comment on the survey is considered part of the survey, even though we are not reporting it up to CMS. I cannot share what they wrote on that survey unless they give permission to. So I include that question there in the hopes that they'll answer yes, and if I need to, I can share that information back with you. That's what the question 35 looks like. It says basically your home health agency may want to review your answers so that they can decide how to address any concerns that you have. We will not share your answers to the survey linked to your name unless you give your permission for this information to be shared with your home health agency. And then the question is very specific. Do you give your permission to provide your answers to the survey linked to your name to your home health agency? And only the home health agency. Still are not providing this information to CMS or to anybody else. And it's either a yes or a no. If they say no, we can't share it. If they fail to answer this question, we can't share it. Link to their name. We can still provide you with the aggregate data. The CAHPS came about with the 2012 calendar year final rule, and then it was, they kind of formalized it in 2013 with participation requirements. And there are two distinct reporting periods within a CAHPS survey. The first one that we refer to is what's called the participation period. And this is the period that is related to your annual payment update. And this is always quite confusing. Thank God, at least with the hospice CAHPS, they start in a calendar year that begins at the January 1st. With home health, all the calendar years start on April 1st. So right now we've just started a new calendar year for CAHPS. And we're looking at visits in April in this calendar year. The first time we survey for this new calendar year will be in May, because we've got to wait till April's done for you guys to get all your April visits in. Then you send us a report, and then we will survey patients that had visits in April and May. So in order to receive your annual payment this year, in 2015, you needed to be submitting your HCAHPS data from April 2013 and submitting for each month with no breaks. You cannot miss a month through March 2014. Looking forward for annual payment in 2016, you need to submit an HCAHPS file for each month through April 2014 through March 2015. And as we start this year, it's going to affect your 2017 APU. So I know that's a little bit confusing, but you can see really there's almost a 2-year delay from the time that you are submitting data to it affecting your APU, and that's just the way it works. Number one, they got to collect the whole year's data, and then once they collect it, we don't report it for a full quarter, or it's not required to be reported for a full quarter. Then CMS does whatever they do with it for another quarter. So there's quite a delay there before it actually they get a final year, and that's why there's that delay from the time that you participate to the APU that it affects. So that's the participation period. The participation period is when you are sending your data to a vendor and which APU it affects. Then there's the public reporting period that is totally operating on a separate schedule than the participation period. CMS began the public reporting in April 19, 2012, and that was on data that they started to collect in the end of 2010 through 2011. What happens with the data is it reflects a 4-quarter average, and it's a rolling 4-quarter average. And each quarter the data is updated. So they add the new quarter in and give you that 4-quarter average that includes the new quarter, and they drop off the old data. Data will not be reported for any home health agency until that home health agency has 4 quarters or 12 months of data. So you have to have that 12 months in, and then there's that delay as CMS gets all that data together, and then it will be reported. And sometimes you won't see your data reported for a couple years. So the period that is currently, like if you went to Home Health Compare right now and looked at the data that is being reported right now, it's data that was actually collected from October 1st of 2013 through September of 2014. So you can see there's maybe not quite a full year delay, but there's a very significant delay there. So the information that's publicly reported on the CMS.gov website will consist of 5 measures for CAHPS. There's 3 composite measures, and they kind of group them into 3 categories. care of patients, communication, and specific care issues. And then they have those 2 global rankings, which I say are really your satisfaction ranking. And in one of the global ranking questions, 20, they asked the patient to rank you on a scale of 0 to 10, with 10 being the worst, or 10 being the best home care possible, and 0 being the worst home care possible. And then would they recommend you, which is question 25. And that's a yes or no. Adjustments of data. CMS does not report the raw data that we collect. They gotta do their little magic with it. They do adjust the data figures. So the data is presented in a composite form, but then those composites are also adjusted for various factors. That is based on an experiment that CMS refers to as the MODE experiment. And this goes back a few years, and I understand they're going to be conducting another MODE experiment shortly. And the MODE experiment included about 25,000 patients from 75 agencies. And what they were doing was they were trying to look and see if there was factors that affected a patient's way of reflecting on their agency, either positively or negatively. Was there, you may even hear from vendors that do telephone, well, if you do telephone, you're going to get better results. So CMS actually went out and tested that premise. Do you get better results if you do in telephone over mail or mixed mode? And CMS is interested in that all the modes be equal, because they want, again, remember, to be comparing apples to apples. And there's a reason why somebody may choose a mail mode over telephone. Number one is cost. If you're a small agency, it's the most cost effective. Why should you be penalized because you're at that startup phase and you can't afford a lot of things that maybe a larger agency that's been around. And secondly, language. In telephone, they generally only survey in English or in English and Spanish. So I have agencies that have quite a few, Russian speaking, and I've had a few that have quite a few Vietnamese speaking, that we send surveys out in those languages because, they're servicing that type of clientele. And if they did it in telephone, they would never have those people reach correctly in a survey because they don't have the telephone interviewers that can speak Russian and Vietnamese. So why should they be penalized because of that? And CMS didn't want that to happen, so they did the MODE experiment. And they tested for, the mode, obviously, that the survey is conducted in, but they also looked at different results on patient characteristics, such as age, health, status, education, to see if that produced different results and what adjustments needed to be made. And I'll give you an example on that when we get into it. So what they found was that the mode had little effect whatsoever. It was found to be small and inconsistent. And therefore, it was determined that they did not need to adjust for mode. So they don't adjust the scores based on the mode that you conducted the surveys in. And that's because there's no need to do it. And if there was a difference in modes, they would adjust the scores. So if, if one mode gave a particularly higher response rate than another mode, they would actually adjust that mode down. If you conducted in that mode, they would adjust your scores down. But the patient adjustment factors that they found did have an effect were age, and they used 65 to 74 as a reference group, education, and they used a high school or a GE as the reference group. So they looked at if you had a lot of patients that were college graduates, maybe more so than the average agency, did that affect how they rated your agency? They found out that people with a higher education tended to be a little bit more critical of agencies' performance than others. So therefore, they adjust for that. Self-reported overall health status or mental or emotional status. If you feel that you don't have good mental health, it may affect how you view your agency. So they adjust for that. Excuse me. There's 2 diagnoses, schizophrenia and dementia, that they adjust for. And this one, dementia, is the one that I clearly see as having an effect with a lot of the agencies I service. I have agencies that service primarily an assisted living facility, and that's where they get 70 or 80% of their patient base. And it's an assisted living facility that has dementia care clients, and they're in a dementia lockdown unit. And some of them are able to, with maybe a proxy to answer the questions. But if you have 80% of your clients having dementia and that affects your score in a negative way, your score is going to be adjusted upwards to account for that. Patients living alone, if a survey is answered by proxy, which is allowable for home health, it's not. With hospice, they're looking for the decedent caregiver, and they don't allow proxy because it doesn't make sense. And the language in which the survey was conducted, they noticed a difference. So they adjust that data, and it's the adjusted data that is publicly reported, and it's going to be a little bit different than what you see from me because of those adjustments. There is no way that I can provide adjusted data to my agencies. I don't have access to the adjustment factors, and earlier this week CMS sent a kind of a hand slap to vendors saying do not even attempt to adjust this data because you don't know what the adjustment factors are and you are adjusting it incorrectly and providing incorrect information. And you should make sure that your agencies know that the data that you provide it may be different than what is actually reported. So I never really adjusted that data because I knew you couldn't adjust it and we could not come up with the actual adjustment factors, and CMS refuses to share it with a vendor. But that adjustment equation, they've shown us what the equation looks like, and that equation is applied to the score for each measure. So they take your adjusted score for the measure, which equals your raw score minus adjustments. And then the way they figure out the adjustments is they take all those factors that I just spoke to you about that affects your CAHPS actual level and provide it and apply it to each measure. And they've calculated how much each one of those factors and developed a coefficient for each factor. And then they will take the proportion of patients that you have with that factor minus what the average agency had. So if you had 80% of your patients with a dementia diagnosis because you service a Alzheimer's facility, and that's kind of where you get a lot of your business from, and the average agency only services 40% with that dementia diagnosis, they're going to multiply that coefficient factor times that difference of 80 to 40, which is 40%, and then they're going to apply that adjustment to your score. Also coming up, and last month we talked about the 5-star ratings, which are going to be part of your outcomes measure. And CMS is using both outcomes data and claims data to develop a 5-star rating where most agencies will fall in a 3-star rating, and then you'll have your sub-performers getting 1 or 2 stars, and then your your elite agencies or the agencies that perform better than average in outcomes getting 4 and 5, scoring 4 and 5 out of the 5-star ratings, and that will be included on that outcomes measure on the CMS Home Care Compare. And they made it very clear in our vendor training, which we do every year with CMS. The vendors do. We have update training. They made it very clear that they're looking at ways to add the HH CAHPS results in. And whether or not they're going to have a separate 5-star rating for HH CAHPS or whether it's going to become part of the 5-star rating for an agency, they haven't quite determined that yet. But you can rest assured that your CAHPS scores will be affecting that 5-star rating for your agency. So that's kind of it about CAHPS. Let's talk a little bit about some of the things that you need to do as an agency. Response rates. We struggle even as a vendor looking at our response rates, how we can increase response rates. We have home health agencies that score or have response rates around 50% or even in the low 50s. We have agencies that have response rates of 12%. What we found is that there are certain things that affect response rates that are kind of above and beyond our control and even the home health agencies. What the average response rate for CAHPS right now is about 31%. That's what we're seeing across the board. And that's for all the different types of methodologies for getting a response rate. What I have found is that there are certain populations that will have lower than the average response rate, including populations that speak a language not provided in the HCAHPS program. So the languages that I can mail out that CMS allows all vendors, I mean, this is the only languages they'll allow that survey to be mailed in, and a lot of vendors don't mail them in all these languages, is English, Spanish, Russian, Vietnamese, Chinese. So we're mailing in all those languages, but I have a lot of agencies that are in pocket areas that may have languages outside of those languages. And the two that come to mind that I've been struggling the most with is Armenian and Farsi. Those are two languages that I see a need for the agencies I service. And for agencies, and I have agencies that are managed, and some of the clinicians are from that group. So therefore, they get a lot of those patients. They have a lot of doctors that will send those referrals to them because they know they have clinicians that speak that language, and they don't speak English. So when I send out that survey, and I don't have a language that matches them, it defaults to English. So we send out a survey in English, and they may not be able to respond to a survey in English. And that is just part of the CAHPS system right now. We are doing a project because Armenian is our number one language that we would wish we could survey in. So we are going to be petitioning CMS to allow us to have an Armenian translation. And then Farsi is probably our second. And then we get everything else is just kind of spatterings. I mean, but those are the two languages that we've seen a large population that we know cannot respond to the surveys because they can't respond to the survey in the language that it's sent out in. So that becomes a problem for agencies that service those large populations. They're going to have a lower response rate. I mean, the people can't read the survey. It's not their fault. It's not our fault. We just have to come up with hopefully a different survey that we can send out to them in the language they can provide answers in. And then also I will tell you that I see home health agencies that serve a large urban or inner city population as having a big drop-off in response rates. And I think I'm not really sure why. I mean, I talked to home health agencies. Somebody suggested that they may think it's a bill, and so they don't respond to it. They just, they're living in an impoverished area and they don't have the means, so they don't even want to open it up because they're afraid of what's inside. I don't know. I've just seen a big drop-off. So if you service a very large inner city or urban population, there is a bit of a drop-off there, and it just seems like it goes hand in hand with that. But there are some things you can do to improve response rates, and we look at agencies that are consistently falling below that 25%, and we are going to be calling some agencies that are having a low, that we can see that there's some things that they can do. I have agencies that I can see that have a large Spanish population, and they send me all their surveys and request the survey go out in English. So seeing if maybe they go through and just indicate which ones should be receiving a survey in Spanish, that would help a lot. CMS has stated that home health agencies can inform all patients during the intake phase or a recertification phase about the agency's participation in the HCAHPS survey. So what I thought would be easiest is that you included something maybe in your opening packet, and when you admit a patient, just pull out a little bit of something saying you're probably going to get a survey. It's very helpful if you comment on the survey and respond to the survey. It helps us, and it also helps other patients as well, because you're reviewing our agency, and they will know whether or not we provide good care. So it's a good thing to respond to that. We are required as a vendor to put our name on the survey with our information. If a patient has a question, to call us and we can answer the question about the survey. And I will say 2 minutes before I started this program, I had somebody that called and was questioning the survey and, you know, were we the people that came out and provided the care. So sometimes when they see our name on the survey, even though we, you know, the cover letter, we put your logo, your name, we have it signed by an administrator, we have your name clearly on the survey in 3 spots. Even though we have all that information, they sometimes will get a little bit confused and they think that we provided the care. So, you know, we'll gently tell them, you know, we just sent the survey out and we didn't provide the care. I mean, I've gone and, you know, looked up their agency for them and gotten their phone number and if they, you know, needed to call and ask a question. But they get a little bit confused sometimes as to who we are. And I wonder if sometimes they hesitate to send that survey in because they recognize your agency's name. They don't necessarily recognize the Novatus. So that's why I think it's good in that admission package just to say you may be getting a survey. It's going to come from this company. They send the surveys out for us. So if you see this survey coming, you know, it comes with a stamped postage paid envelope, so you don't have to pay for postage. If you take a few minutes to fill it out and send it back to them, it's very, very helpful to us. You are not supposed to aggressively, you know, try to encourage them to fill out a survey in any particular way. You're not supposed to, you know, in between, again, admitting and recertifying, you know, encouraging them to fill out surveys. They want the patient to understand that this is totally up to them to do the survey. It's not going to affect their services if they don't participate. That's another fear that people have is when they call us, well, you know, I can't find it, you know, and I feel like I'm going to get my services cut off if I don't respond to the survey. So, but at admitting and recertifying, it's nice to give them a nudge and just say, you know, you're going to see this. It's going to have this agency or this number on it. Please take the time to fill it out. You need to make sure that your staff are, you know, aware of this, you know, so that they, if somebody asks them about it, they say, yeah, it's a survey, you know, it's about us. It's totally up to you. Your information is, you know, not connected to your name unless you want to share that, and you have the right to refuse or to participate in the survey. It's totally up to you. So we do have a tool if you want to use it. This is something we developed to be, you know, kind of slung into that opening packet. We made our logo there, you know, prominent so that they'll recognize that they may see that name on the survey. And this tool was designed so that it could go in an opening packet, and whoever is opening the patient up can pull it out, and it has 2 or 3 brief talking points about what the survey is about and what they need to do without, you know, going into gobs and gobs of detail. So it gives your nurse or your therapist or whoever is with the patient something there that they can refer to and has the information there so that they're not forced to have to remember, oh yeah, you know, how do these surveys work? I mean, do they have to fill them out? You know, when do they have to fill them out? There's just the basics that they need to know about the survey. But it's generic, and I can send this to you if you're interested. It's great if you just print them up and put them in your opening packet. Here's where the data is right now, and I included Michigan in here because I'm in Michigan. But each state has their benchmark, and then there's a national benchmark. What I am seeing is this is varying very little from one period to the next. I actually had my data from this time last year, so in a full year, I think 2 of these measures went up or down 1 point. So I think the national went up to 88, it was 87, I can't remember, maybe it was percentage of patients who gave their agency a rating of 9 to 10 was at 85. But you can see where these scores are, and this is where all the agencies nationally that participated, 88% said that patients reported that their home health team gave care in a professional way. And for the global ranking, 84% gave their agency a ranking of 9 or 10. So when I look at this, I'm going to show you a little bit of where this falls out. There were 7,800 agencies that participated in this period with out of 12,000, almost 12,300 certified home health agencies. So there are some agencies that are, newly certified, so they're exempt, or their patient census is below 60, so they're exempt. And there's probably a few that just aren't participating for whatever reason. And there's still some out there that don't even know they need to participate. I talked to a few that were just not even aware. I can't believe that they're not aware, but that is what it is. So for the global ranking, which is the percentage that gave that 9 to 10 rating, saying this is the best home care possible, so that percentage for national is at 84%. The bottom 5% of the agencies in the United States, the bottom 5, which is about 390 agencies, scored 68% or lower on this ranking. The top 5%, again about 390 agencies, scored a 96% on this ranking. And then the global ranking score is the percentage that would recommend this service to a family or friend. Nationally, that ends up being 79% said yes, they would recommend this to a family or friend. The bottom 5% is scoring 60% or below on that. The top 5% is scoring 93% and higher. So that gives you an idea. So if you're looking at, if you're getting around 70% on that bottom 5%, you need to start looking at your CAHPS scores and making sure that, you're raising that scores. The next thing that's going to happen with these CAHPS scores is they're going to be part of that 5-star rating, and eventually what they're looking at is it's going to be not a fee for participation, which is what you see now. You get, you get your full APU if you participate. You lose 2% if you don't participate. Hospitals have moved into fee for performance. So the top agencies get reimbursed at a higher level, and the bottom agencies get reimbursed at a lower level. So you want to look at those scores now, because you'd hate to be caught with your drawers down if they do make this change. They haven't said if definitely they're going to make the change, and they haven't said when that change would occur. But they have said that is, I think the term that they use, a likely possibility, whatever the hell that's supposed to mean. Excuse me, but Medicare can be very vague in their language. So, keep that in mind right now about this CAHPS data. So when should you be concerned? Generally if you're falling below that benchmark value for either your state or your national averages on any measure. And you can dial back that measure. That's why we do those reports in the format we provide them with. You can look at which are the composite measures and which questions fall within the composite measure, and then look at the questions that relate to that. And if you see that you're falling, and generally what you will see, and I will tell you this because I've looked at a lot of agencies that were struggling with some of their scores, is that there's usually 1 or 2 questions that you're scoring very poorly in. And that can be a very quick fix for you. If it's a patient care issue and the one score that you're falling below an average, which is pulling down your whole score for that composite measure, is did the nurse or did the provider talk to you about how you can move safely around your home, and you're getting a low score about that? Well, the quick fix is, talk to your field staff and say, make sure that every patient that you see, that you ask that, that you address that issue with them and ask that question: are you having trouble moving around? Is there, have you looked at how you can make your home safer? Just bringing up that conversation, so when they get to that question, instead of saying no, they're saying yes. And the next thing you know, that question score pops up, and your whole composite pops up. So we do provide that information in that question-by-question format so that you can look at exactly where you have your problem. Couple things that we looked at: agencies that scored under 70 in that global ranking. You can go back and you can see that they were having patients rate 6 or below. Usually when a patient rates 7 or 8, they're kind of indifferent about the care. They didn't think it was great. They didn't think it was bad. When you start getting into a 6, it is a real kind of reflection that the patient was very dissatisfied with care. Even though they rated you a 6, it may not sound like that, but in global rankings, that's the way it works. In fact, Harvard did a study, and they have what they call an NPS score, and they say it's the #1 indicator of whether a company will be successful and profitable is that NPS score. And that NPS score is based on a question that looks a whole lot like those 2 global ranking questions if you combine them together. The NPS score asks, how likely are you to recommend this service, this product, to a family or friend on a scale of 0 to 10. And to evaluate an NPS score, they take those that rank 9 or 10 and subtract the percentage that ranks 9 or 10 and subtracts the percentage that rates a 6 or below. The 9s or 10s are considered promoters of your agency or your business or your service. Those that rank a 6 or below are considered detractors, and that 7 or 8 are just indifferent. So you take that score, the percentage that you have ranking a 9 or 10, and subtract those that rank a 6 or below, and that score that you get, that percentage that comes back, indicates whether or not your company is going to be successful and will have growth in the next year. And Harvard puts a lot of store on this question, and every single major corporation will evaluate their NPS score. It's a big thing right now, and you can see a lot of that in some of these CAHPS things. So pay attention to that global ranking. There is a strong correlation between agency census and lower ranking. And that's because if you get one person that's a little bit unhappy and they rank you low and you don't have that many others to cover up, it can pull your rankings down. So we really look at, are we getting the best response rate to get the best scores? And a lot of times if we work on response rate, we up the scores quite a bit. When we see that low, if we see an agency with a low ranking and a low response rate, the first thing we do is try to get that response rate up. And then there's also strong correlation between home health agencies that serve patients and kind of like Department of Protective Services or Medicaid waiver, or dealing with a population that is frail, vulnerable, lower income, elderly. They seem to have lower rankings, and then those that serve in facilities. So here's your report, just in case you haven't had a chance to look at it. Composited measures. HCAHPS, again, measures across 2 domains, field staff and office staff. When you're underperforming in a composite measure, you need to dial back to the actual questions that relate to that composite measure. I'm going to quickly kind of run through these slides. Composite measures, these are the questions that relate to them. And it's themes of knowledge, informed and up-to-date, gentleness, courtesy, and respect. Some examples there of the questions. Communications, how informed were they? How well did you communicate with them? There's 7 questions that relate to this. Did they listen to you? Did they explain things in a ways that was easy to understand? Did you get a response from the office when they call? And then specific care issues related to medicines, pain, and home safety. These are the questions. So those are specific care issues. The one that I find that agencies rank the lowest in is question number 3. When you first started getting home health care from this agency, did someone from the agency talk with you about how to set up your home so you can move around safely? This is by far the #1 question that we get the lowest ranking in across the board. Not every agency, but as an aggregate group, that's the one that I see the most issues with. And it's just a matter of making sure your field staff are, talking to their patients about this issue. So let's say you have great results. What do you do with those great results? You need to get out there and you need to spread the news. If you have a marketer or you have a liaison, they have an opportunity to go out there and differentiate your agency in a way that's easy for the consumer and the referral source to understand. Outcomes measure is a little bit more difficult to understand what's going on with the outcomes measure. But home health CAHPS, it's about how happy, and what the patient's experience is with the care. So when you go out and you talk to physicians, it's about when you refer a patient to us, the patients are happy with the care that they get. They feel like they're making progress, that they're getting a good experience with the care that they get. So that's something that's very easy to share with people and can make quite a big difference and can really differentiate your agency in a marketplace. There's different ways that you can share that. Certainly with any of your face-to-face marketing encounters with physicians and hospital case managers or discharge planners or rehab facilities or facilities SNFs, ACO network executives. You can do that face-to-face. You can mail an info or flyer to your referral source. You can put it up on your website if you have great scores. If you have a Facebook fan page, it's something to put up there. If you have a newsletter or blog, you need to know not only your patients and your referral sources, but also your own staff know if you're doing well in these areas. I've seen agencies take out advertisements in papers or in like a mature advisor paper and talk about their great scores. And press releases, if you do well, doing a press release. Or on Post-its. If you're getting that face-to-face encounter form, signed by a physician, having a little Post-it, instead of just, an information or a note, please sign this, have a Post-it that says, check out our great CAHPS scores. We're above benchmark in all 5 measures. Very powerful. Anything that physician that makes those referrals looks at that has a marketing message, because you get so little face time with these docs these days, is great. So if it's saying, giving them a positive message at the same time, they're going to start paying attention to that. Your liaisons, if you have to have them, need to be, knowledgeable about this. They can't just say, well, we got great HCAHPS scores. They've got to be able to answer the question, well, what's HCAHPS? What's the purpose of it? Who gets surveyed? What type of information are you asking? And then, of course, what are your agency's results and how do they compare to other agencies? And then, finally, what I do a lot of sales training with liaison, and one of the things that I see that's so lacking in their sales encounter is they deliver these messages, but they never really think about why that referral source should care about the results. You can go out and you can say, we got great scores, but, a lot of your physicians are saying, well, big whoopee-doo, in the back of their mind. So you need to articulate why they need to care about that. We're trying to make this a little bit easier, so we're looking at our agencies right now that score above national benchmarks. We do this in all quarters on all 5 measures for 1 year. We're looking at nationally, there's about 20% of all the participating home health agencies will meet these standards, meaning at or above the national benchmark for all 5 measures. We've created a certificate that you can put in your foyer. We've created a press release that you can drop within local newspaper. You would be surprised what a local newspaper will put it in the paper when they're looking for, filler items. It could be just your press release saying that you scored in the top 5, or you scored in the top, 20% of all agencies, or 5% of all agencies, or you scored, above national benchmarks in all 5 quality measures. They will put this in the paper just because they have space to fill. Or it may spur a reporter to talk about home health care and want to do a full article, and the first thing they do is they call up your agency and ask to speak to somebody there that can give them enough information so they can start writing this article. And we have a little bit of a logo, so you can put it on your, your website and your Facebook fan page. And then we created a sell sheet too for liaisons to use when they go out. The referral sources need to know why this information is important. You just can't deliver that information and say, hey, we did really good in this. That's great, and it's better than nothing. But they need to know why they should care about it. So here's a typical educational exchange, as I will call it, of a liaison when they go out. And they use what I consider a typical sales model, which is the feature and benefit sales model. So they're taking a feature, meaning your feature is you scored above the national benchmark in all 5 measures. That is now a feature of your agency. And they're putting it in a benefit statement. So the feature statements are CAHPS results on all 5 measures are well above the national and state benchmarks for home health agencies, Dr. So-and-so. And this means that when you refer to us, you're referring to an agency that provides quality cares that the patients appreciate. So that's kind of the benefit. You know, the patients are happy with the care. They feel like they were well served with the care that they got. And a lot of times I've had liaisons say, well, you know, the physician just didn't seem interested. I don't think he really cares about quality care. And that's probably not really what's going on there. They still don't know why they should care about this. The HCAHPS surveys, you need to explain to them why they should care about it. The HCAHPS surveys support the push to patient-centered care. They're being pushed to patient-centered care. This is something that they hear buzzword from Medicare all the time. The AHRQ acknowledges that patients are the only reliable source for understanding the quality of the patient experience, and satisfaction with a home care agency is often reflected back onto that source of referral. So when patients are happy with the care that they get from the home care, it reflects directly back on who made that referral. And I know this to be true because I handle those calls from people, and the first thing they ask me is, well, am I just commenting on my home care provider, or should I include my doctor in this? Because they don't separate that. If they went into a physician's office and that physician made that referral to home care, they look at it as being kind of part of that, what that physician is delivering. And when they are really happy with the home care agency, they are happy with the physician. And physicians need to be more and more aware of this and paying attention to the fact that patients are happy or unhappy with them, because they're starting to participate in their own CAHPS program. Physicians will be participating, if they're part of a group practice, they have a CAHPS survey that they will have to be doing called a CG CAHPS, and that will reflect directly on that physician. So, you know, it might not have anything to do with what that physician delivers in his office. It still means that that patient is really happy with that physician because he made, you know, he or she took the time to refer him to that wonderful agency, which is you. And it really does reflect directly back on them and the satisfaction they have with their physician. So that's why they need to care about it. So, you know, if you remember back to that feature benefit statement, what we try to train our liaisons to say, or maybe it's you when you go out there, is you can see, and ABC Home Health is my generic home health agency that I use. You can see that ABC Home Health scored above the state and national averages on all 5 measures. And they can see it because you have this nice little sheet that shows it to them. In fact, over 90% of our patients rated our agency as the best home health care possible. This means that you can feel pretty confident that the patients you refer to us will be delighted with the care they receive from ABC Home Health. And we know that that satisfaction reflects directly back on your practice. And that's an important consideration for any physician or practice as they move to patient-centered care and participate in CG CAHPS initiatives. And, you know, the hospitals are drumming these CAHPS figures down their throat, too. Hospitals are doing their own CAHPS. So they are hearing about the importance of getting good CAHPS scores. So this might be the reason why they should care about it. Not just that you have it, not just that you did well at it, but the reason why they need to pay attention to that and care about it and make sure that they're referring to you because you're going to help drive that for them. So this is the sell sheet that we do. We actually load in your logo, your contact information, and your scores on this sheet for you. And this is for everybody that gets that national benchmarking ratings above 5. If you're interested and you're doing well on a few of them and you want to do something with that, you can call me. If you want something like this. The way I use this form is I would use it with a liaison that's making those calls to physicians as a talking point. I've used it and I've mailed it to some of my referral sources, or I dropped it in the Dropbox of case managers at hospitals that talk about our scores. And it's a very nice professional piece. We have a graphic designer here in-house, and she designs that. The content and everything and the layout is pretty standard. We're not going to change around on that a whole lot, but it's a nice piece. It looks professional for your agency, and then we try to, you know, make it look like it's your piece, branded to your agency. Just a little bit about ICD-10 codes. Should say October 2015 is when it all happens. It's not a revenue opportunity in the sense of, I look at this as a way for marketers to add value on their sales calls, but just be aware that it is coming. Most likely, if you're on a software program, they have plans for switching over to ICD-10, but you may be wanting to talk to physicians when you're out there. I did map some of the top codes that I'm seeing, and then looked at, mapping them over to the ICD-10 codes. Start talking to physicians now about transition to ICD-10 codes. Look at your top physicians and look at, the diagnostic codes that they're referring under, seeing if there's some, definite trends there that you can go back and talk to them about specific ICD-10 codes that you would expect to see from them. So I'm going to try, and I think it's *1. Let me see if I can unmute everybody here. Maybe I can do it on the console here. Hang on. Okay. I was able to unmute one, but not everybody. If you have questions, you can email me questions. We're excited to have had you on board today. If you would like me to mail the sheet that I have for the opening packet, but look for our Circle of Excellence Awards. You may be qualifying for it. We'll be looking at where your agency falls and notifying those that fell in this last period that just went up and is being publicly reported now. Because you need to get that information, and you need to celebrate it within your agency if you're doing well on these scores, because it is something to celebrate, and it does reflect on the quality of the care that you provide. So that will be it for today. I'm going to sign off. Thank you again for attending, and I hope that this was helpful.